panelists here. I want to welcome you tonight to this League of Women Voters Forum. I'm sorry there aren't more people here. This is a crummy time of year, but we thought it was an important forum to have to get information out to the public so that people who are traveling won't be unduly alarmed, but also will be cautious about infectious diseases. I'm Sydney Walter. I'm a co-president of the League of Women Voters of Laramie. Judy Knight is the other co-president, and she is home ill this evening, unfortunately. Linda Pena is going to be the facilitator of this panel tonight, and so she will introduce the panelists and get us rolling. And we're going to not have time limits per se, but ask, if the speakers run on a little long, then Robin or Lynn will say, let's wrap that one up and move on. So, and there will be plenty of time for you to ask questions afterwards. So we do thank you for coming. Lynn?
All right. Thank you, Sid. And I'll try to speak loudly also. So my role tonight is, to begin with, just to introduce our panelists one by one, and then they will give you a bigger introduction. So Bill, should we start with you?
All right. My name is.
Okay,
go
ahead.
Start with the name and introduction, or you want to get all of us first?
Why don't we just start with you?
Okay, sounds good. My name is Bill Heister. I'm the Albany County Public Health Response Coordinator. Essentially, I work preparedness, exercise and planning for local responders, and then also community preparedness when it comes to infectious diseases. I maintain, develop, and coordinate plans throughout the county and the city for things that might be related to infectious diseases. So, are we good?
I think we
We have a technology person.
All righty.
You just had to turn up the volume.
Let's try this.
You try that one.
Okay, now.
Hello. I'll keep it over here. Can you all hear me now? I'm going to turn your speaker around right at you.
Maybe you could just repeat the gist of it.
Okay. We're good?
So you're the only one that's good now.
All right. You got the game down? All right. So for what you didn't hear, the other pieces that I do is I coordinate with a lot of the jurisdiction partners when it comes to the county commissioners, county clerk's office, sheriff's department, the fire department, county emergency manager, and coordinating anything that may be related to logistics or support that when it came to, or if it came to natural disasters, or anything like an infectious disease, public health emergencies. There's a myriad of things that public health would be responsible for in response and supporting the county in how they would react to an issue or a concern within the county. So my role is primarily supportive. I coordinate things with the state at the federal level and with a lot of the partners here in the city and county to basically affect a solution to help solve problems if it came down to a disease or a natural disaster like flooding, things of that nature. So that's my role.
So I'm Kevin Berry. I'm a PhD candidate in the economics department at the University of Wyoming, and my research is focused primarily on infectious disease and risk. I've got an association with the National Institutes of Health through a grant that I've been working on. I also work with an organization called EcoHealth Alliance, which is based out of New York, and they focus on emerging infectious disease, especially ones driven by contact with wildlife, and things like globalization and climate change. And so as far as what I would do directly during an outbreak is mostly just trying not to be infected. Indirectly, most of my work is focused on suggesting better policy to try and prevent future outbreaks and also adapt to current ones. So currently I'm working on what should have been spent as far as prevention before this current outbreak, and how should we be investing that money as well. So a little bit more of a global perspective rather than a local perspective. A lot of we should be building health infrastructure and doing things to improve public health in developing countries as sort of an insurance policy to protect us here from outbreaks, because obviously if Ebola had never happened in West Africa, there would be no threat here.
And since you're talking about yourself, how did you get interested in this area?
So the beginning goes back to working with my advisor, Dr. David Finoff, who was not able to be here. He sort of drove my interest. I was a little bit more interested in the math to begin with. There's a lot of fun math models for infectious disease. I probably shouldn't call them fun, but yeah. So it was interesting dynamics, and then it's just a really policy relevant problem where you have the ability to do a lot of good in the world. So hopefully some of the math I'm doing is doing good in the world.
Okay, well, I'll give a little bit more of an introduction than I did for Kevin. This is Dr. Pamela Clark. She's from the university. Pamela, I'll let you carry on from there.
Okay.
So there's a little button on the side. Push it up.
That's not good for anybody's ears. I'm a public health nurse by trade. So as soon as I got out of nursing school, I went into public health. I worked 15 years directly in public health in the city of Detroit during a time when there were small epidemics and fear of smallpox, and you know, we were still doing the smallpox vaccination back then. And that was my practice experience before I went into education. I have a master's in public health and a PhD in nursing. My master's is from University of Michigan, my PhD is from Wayne State. So then I went into teaching public health, so I've always been interested, I stay interested in the field, and it was particularly interesting this semester because I knew I would be teaching epidemiology coming up in the fall. So when all this started this summer about Ebola, I thought, oh, that's so great. It can be the focus for my class, and I had to redo some things to have a continuous thread. It's an online class, but you don't get many opportunities like that for students really to study what can happen when something's literally out of control. And we talk a lot about the situation in West Africa, the importance of attending to that, the difficulty of following up contacts. I did tons of that, trying to find contacts for tuberculosis or sexually transmitted diseases. And so I know you have to have the trust of the community, and some of those things that I sort of thought were violated along the way. So I'm glad to be here, and I'm not glad there's an epidemic, but if there was going to be one, I'd like to be teaching epidemiology, which I am. I think.
At the end of the board. All right, don't feedback.
All right, and our fourth panelist is Wanda Hewlett, and Wanda is from Ivinson Hospital. Let's see if we can get it to work. Hold on, just been on, turn up the volume.
Can you hear me? Yes, you can hear me now. As she said before, my name is Wanda Hewlett. I am by trade a respiratory therapist, and I work at Ivinson Hospital. I have several different hats. I actually have one hat. My first hat is actually director of cardiopulmonary department, and so I have 10 staff that work 24/7, treating you if you have any breathing problems, and also if you have cardiac type issues, EKGs. We also do sleep studies and that kind of thing. My second hat is I am a coordinator for the basic life support classes, the CPR classes there at the hospital. So I do that monthly in conjunction with about 15 instructors that we have. And my third hat is emergency preparedness coordinator, and that's what brings me here tonight. I have been doing this position for several years. We do have an inter-hospital team that has several different members from different departments on our team that talk about how we can be more prepared for emergencies. And as I teach every month to our new people that come to orientation, I start out with asking their name and give me an example of a disaster. And of course, sometimes we have up to 15, 20 people in that room. And the point is that there are all kinds of disasters. And also we talk about kind of a general response plan, because a lot of the things that you would do for a tornado, say, or a mass casualty incident, or a flood somewhere, which we're glad we're not in the floodplains up there in the hospital, but a lot of the responses are the same. So we operate on the ICS system, Incident Command System, same system that the fire department, police department, a lot of different agencies operate. And so we're all talking the same language when we are responding to an incident or when we're training. Bill with Public Health also teaches that system through the things that he does. We both belong, or our members of our agencies belong to a county group called Community Health Emergency Medical Preparedness Group that meets anywhere from once a month to about once every 3 months. And we have, probably if everybody's there, a good maybe 30 agencies within the community here that meet and discuss different issues. We do have a university representative, actually a couple on the team, and they come and bring us, okay, how is flu going at student health? Dr. Steen is a member of our group, and so we come together and we try to keep each other informed as to things that are going on, and also things that are coming that may be issues for, say, our emergency room at the hospital. A few years ago, we had a team from Texas here playing football around Labor Day weekend. We also had the music festival at the fairgrounds, and we had a first high school football game, and there was a dance downtown, and all kinds of things that we as a hospital may not have been aware of at the time, but those kinds of things, having an additional 30,000 people in town for a Texas football game, where they come from an altitude of like 0, and they're coming to 7,200 feet. We were all aware that, okay, we might need some extra oxygen this weekend for these people. It makes us more aware of planning, and so we can better respond. Some of the things that we're doing for Ebola, as soon as the first case in the United States was announced, we started talking about what do we need to do. Now, the odds of things coming to Laramie, everybody said, it never will happen here. Well, we have a lot of international travel here because of the university and because of some of the companies that, it's amazing to me how much travel goes on. And so we immediately thought, we need to be prepared. So we formed an Ebola task force, which again has members from about 10 different, departments. We have also the first responder, fire department, EMS, county health officer, Gene Elias, and some of those folks on our team, and we started talking about what ifs. And we developed an additional policy. We actually had Ebola on our infectious disease list, but we kind of beefed up that policy. We were very aware of all the changes that the CDC is making. There's so much information out there now that it is hard to wade through what is really what you need to be, aware of. But we did also beef up our Tyvek suits, our supplies, our goggles, our gloves, and all of that kind of thing. We also have been going through some ongoing training with different departments that would be involved in that first responder type incident at the hospital, so that we are practicing what they call the donning, the putting on of all the equipment, personal protective equipment, taking that off properly so we're not infecting each other, that kind of thing. So we've developed a team that is doing that. So we also have an area, we have a plan for if a patient comes to the ER, how we're going to treat them, where we're going to put them, how are we're going to isolate them, that kind of thing. We also have, through this team, talked with the ambulance guys. What are they doing when they get a phone call that says, I'm really sick, 911, you need to come pick me up? Well, they are also asking questions about, do you have a fever of a certain level, and have you been to West Africa within 21 days? Gives us kind of a red flag, and then their plans for what we do from there. We are able to care for a patient for a few days here at the hospital. Some of the hospitals that you're transferring people to will not accept people unless they have a confirmed diagnosis test from, the CDC, or the state of Wyoming lab in Cheyenne now is equipped to do those tests, the confirmatory tests, so we could get results earlier, but some of those patients would not be able to be transferred right away. So we realized we needed to be ready, to at least keep some folks for a few days. So we are ready for that. We've got our equipment. We've talked to the ambulance guys have some plans also. You know, we can't be perfect, but we are addressing issues. And I guess that is what I'm here to talk about from the emergency preparedness side. Thank you.
Thank you, Wanda. That was very informative. Well, we have a fifth member of our panel. This is Kevin Lamb from the Laramie Fire Department. Kevin, would you like to talk about your role?
This is going to be pretty easy, actually.
Okay.
Just what Wanda said.
No, you can't do that. That's not fair. Now it's going to be hard.
All right. Yeah, my name is Kevin Lamb. I'm a company officer with the Laramie Fire Department. I've been doing this job for about 15 years. Like Wanda, I wear more than one hat over this bald head of mine. My primary role is as a mid-level supervisor for the fire department. So I'm in charge of a station. I'm in charge of a fire crew. My role is to supervise firefighters and operators for my particular station. Another one of the roles that I have with our organization is I'm the hazardous materials coordinator for the department. Okay. Now, what that means in the context of the infectious disease policies is what are called CBRNE, which is chemical, biological, radiological, nuclear, and explosives. Those are the primary target hazards when you're dealing with what's called a hazardous material. Now, the second one, the B in that, biologics, is where your infectious diseases fall right in. Those also include things like wanton attacks such as anthrax, ricin, some attacks like that, but we're also dealing with things that are either natural, man-made, or accidental. And in this case, as far as an outbreak within Ebola, we're dealing with a biologic and how our response should be geared towards dealing with an outbreak or even if it's an isolated case. Some of you may or may not know, in addition to providing fire suppression and hazardous materials, I can probably just, here, is that better? Not as much feedback? Okay. Not only with the firefighting that we do and hazardous materials response and technical rescue, we also work through the hospital to provide the only transport, or the primary transport ambulance for the entire county. That's what the Laramie Fire Department does. So we are the first responders that are going to be interacting with a patient in the field, assessing them, evaluating them, stabilizing them, and then bringing them to the hospital. Now, in the context of an Ebola patient or another infectious disease patient, we do have those screening processes in place that we're practicing now, that not only if they're presenting flu-like symptoms, we go a little bit deeper into the screening of, have you traveled within the last 21 days? Have you been exposed to someone that has traveled in that last 21 days? And these are recommendations that come from the CDC about when a potential outbreak is, when a patient is infectious, is when they're presenting symptoms, and then the incubation period is anywhere between 2 and 21 days. So we include that screening process, not only with our own questions that we will ask when we're on scene, but also our dispatch center will be asking those questions. When they get that 911 call and it's for flu-like symptoms, I just don't feel good, I've been throwing up, those type of things, they include that question in their computer-aided dispatch model, so that when they give us the call out to go to address XYZ, then we have a little bit more forewarning. Now, that has generated yet another protocol. If we have a suspect case on a response that we may be dealing with somebody that is infected with a disease like Ebola or typhoid or something that is horribly contagious and not very well able to contain, we have prepared ourselves with appropriate personal protective equipment, PPE, that will not only protect us so we don't become exposed, but also help isolate that patient and get them to the care. Our primary delivery point is Ivinson Hospital. There are also things in place that if we do have a stable patient and then the receiving facility is Denver Health down in Denver, that's where we may be transferring this patient, and that may happen directly from the scene. That's going to take a lot of coordination between our organization and the ER physician on staff at the time to make that determination about whether we go directly to IMH or we go bypass and go directly down to Denver. That's not the call that the crew in the field makes. They get a lot of feedback on that before we make that call. Okay. So basically, in a nutshell, with the fire department, I represent the first responders that are going to go out and see half of the patients that we're going to see. Half of them are going to show up at the hospital on their own. The other half are going to call and say, hey, I need some help, send me an ambulance.
All right. Well, thank you very much, Kevin. I think we've learned enough, maybe we can all go home now. But we shouldn't go home yet. I made some questions that I could ask our panelists, unless someone in the audience has a burning question they'd like to pose. Anyone?
I'll ask a question.
All right.
You
Robin
mentioned
Hill.
that there's about 30 agencies that you meet with every month for emergency planning. What are they besides hospital, fire, police, the county?
So
We
here,
do
just
have-
in case you didn't hear what Robin is asking, she wanted to know what those 30 agencies are, or who they are,
I'm just
that they
curious.
meet with.
We normally don't have all 30 in one room at one time, but there are that many that do come at some point in time. Gem City Bone and Joint, Urgent Care. We have invited some of the pharmacies and pharmacists, but it's hard for them to get away. Bill's Public Health. We have city folks, we have fire department folks, we have EMS folks, we have county. A lot of times we'll have a couple of people from the PD. There may be Stalder, but we also would have maybe Rob Debris or someone else come. Sheriff O'Malley is in regular attendance. We do have Kevin and some of the guys that are, if they're working on a specific project and going to report for us, they will come. We have had the school district, Mike Hamill from the school district has been in attendance. Jeff Lewis, when he was transportation director at the school district, we did have an incident a couple years ago where some kids at the one of the elementary schools were trying new foods and fruits. It was a program that we're supposed to introduce different things to people, and they ate, a bunch of elementary school kids ate some yucca that morning. Well, one of the people, I guess, that was serving the yucca realized that sometimes I guess you have to cook yucca before you're supposed to eat it. And I guess I need to be in this program because I learned all kinds of stuff during this incident. But about 30 minutes later, we got a phone call that there was going to be 65 elementary school kids come in a bus to us in about 10 minutes. And we're like, talk about emergency response. We learned a lot from that particular incident. We had one little girl, I think, that vomited once, but we think it was mainly anxiety. So we didn't have any terrible outcomes from that incident, but we learned a lot about communication and how we needed to involve the school district and kind of learn what their policies were and communicate that way. So sorry, that was a tangent, but that was one of the agencies that are there. Who else, Mr. Bill?
Army National Guard,
Army National Guard.
and then we have ARC.
ARC has a representative
Peak
that comes.
Wellness.
Peak Wellness. We have had LCCC people come because we've done some drilling with LCCC. University also from like pharmacy school and sometimes nursing school. We have involved them in pod drills where we have, a couple years ago, there was a drill at the field house where we tested the notification system through university students for them to come and get, it was a drill, but come and get, pills if we needed to hand out Tamiflu. And they actually came and got t-shirts. It was kind of cool. And they involved the pharmacy students with, when you come in to something like that, you usually have a little form that you fill out and says, what kind of drugs are you on? Well, if you're on certain drugs, then we had the pharmacy students look at that list, make sure it was okay for them to get the Tamiflu, that kind of thing. So we've involved pharmacy and nursing students from that program. Civil support team from Cheyenne.
Yep, and then we have County Emergency Manager.
County Emergency Manager Amy Benning. And we've had different types of agencies, come in and like Tri-Hydro came in one time and gave a presentation on some software that they have that can, if you're trying to detect what someone is exposed to some kind of a substance, it will help you figure out what that substance is, and then also will tell you what kind of treatment you need for that patient, and then also what kind of protective gear you should have. That kind of thing. Oh, UP Railroad sometimes comes. We had a drill with them last year and simulated a tank overturning. And they actually brought a training car from Chicago just to Laramie, Wyoming for this drill. It was pretty awesome. The fire guys got to drill actually with this training car that had a hole in it on the top, and they could put water in it. It would simulate gas, chlorine gas being spewed. So, they're part of our group too.
And
Does
the
that help?
highway department, maybe?
Highway department has not been at that particular group, but certainly could be. We do have another group called Laramie LEPC, Local Emergency Planning Committee, that meets quarterly, and they do have, Red Cross
Yeah,
is also there. They do have, with the Laramie Emergency Planning Committee, we have streets and alleys, we have the highway department, we have some of those other agencies that are involved, in planning. And one of the things that we looked at that I wouldn't have thought about with this group in that team was, okay, we closed the roads, all these semis are backed up, you see we have a plan for that because we do that very well. We exercise that a lot in the wintertime. But what happens if we're shipping some cattle, for example, and that road is closed? What happens to those cattle? Where do we put them? Well, we decided we'd probably put them at the fairgrounds. We got okay for that. Now who's going to feed them? Who's going to take care of them? That kind of thing. So that kind of group works on that kind of more county. And when we had fires a couple years ago, that group was very active. Both of those groups were very active with, Red Cross shelter being set up. We actually had, one of the duties that I had was find some food for the llamas in the fairgrounds. I'm like, well, what do llamas eat? I don't know. So what did I do? I called a couple vets and said, what do llamas eat? Hay. So we called and got them some hay. So when we had to evacuate some of those people from up the Snowies, they came to the fairgrounds. We had all kinds of water. We had a shelter. We had all these things taken care of. And we have a very good networking system in that one day we had at the hospital, we had a freon leak in one of our cooling thingies somewhere. I know that's not the technical term, but I got a call at 7:30 in the morning. Usually I go to work at 8. I got a call from Dan Johnson at the fire department, who is on our CHEM team, and he said, I don't know if you know, but there's a leak at the hospital, a gas leak at the hospital, and I thought maybe you should know that because you're probably not at work. Now, how amazing is that? We have good networking. Also, when we had the Yucca incident, I actually got a phone call from the emergency preparedness guy in Fort Collins at MCR saying, what's going on up there? I hear you guys have an emergency. What can we do to help you? It's a very tight-knit group, and we help each other. And it's a very huge advantage that we live in a community like we do in Wyoming. I would hate to be in New York and try to contain something. So I went off track, but does that answer your question?
I think all the tangents have been really interesting. Ollie, you have a question?
Well, I thought the response that came out of the Dallas incident was rather embarrassing. I mean, how do you prevent the hysteria? Remember that the nurse that was flying from Dallas to Cleveland, and schools were closing.
They locked her in a bathroom, the nurse on the airplane?
That's how do you prevent that kind of hysteria, which is almost worse than the disease, in terms of the overall impact?
I think we all heard Ollie's question, but how do you prevent local hysteria,
Right.
like his examples?
Well, and it's throughout America, the hysteria is.
Which is why we're meeting.
And,
If you didn't hear Sid, she's saying it's that hysteria that prompted this forum.
And I noticed even in my student group that they were more concerned about the Ebola here. West Africa is far away, and I kept trying to refocus the discussion on if we don't focus on West Africa, more and more people, it's going to spread. And so I kept leading the discussion back to West Africa, but a number of the students were really focused on themselves, their families, their communities, learning to put on the protective equipment and so forth. And I'm thinking, we have bathrooms in this country, we wash our hands all the time, it's totally different scenario than in West Africa. So the likelihood of an epidemic here is nil, really. You know,
the way- also
almost
the way,
now.
The way they treat anybody from West Africa.
Right, oh, yes,
you know?
yes,
That was
right.
the embarrassing part.
Yes, and I did think the Dallas situation was just really embarrassing, the way they didn't bring the guy in the first time he came, and then even some of my students accused him of lying on the sheet that said, "Where have you been?" And you know, we don't usually call our patients liars, and usually they aren't lying. They're either interpreting information another way. They may not read the sentence correctly. They may not be even aware of what they've been exposed to.
I wrote down to myself, Pamela, that when you were speaking first. Sorry.
So it's interesting too that you mentioned the hysteria as well, because especially when you talk about in developing countries, so the World Bank had a report and they talked about damages from this outbreak. And the vast majority are driven by what we call aversion behavior. So there's a pandemic, so you stop going outside. So we're talking about, in the developing world, this is a couple months old number, like $600 million in economic damages from people staying at home. And this is all driven by panic and things, and it's only made worse when people hear panic, because then you have additional damages, and especially if you did have things like, say, banning travel to developing countries, you make it harder for first responders to get over there. So Doctors Without Borders is one of the main organizations fighting this right now. Their volunteers have to come from somewhere, and a lot of their volunteers want to come home at some point and see their families also. So when you make it more difficult for people to get there, this sort of hysteria can also damage our ability to fight these outbreaks where there is a legitimate risk, because while there is a threat to Laramie, Wyoming, it's much smaller than the threat to Liberia or Monrovia or any of those countries over there. So the hysteria is sometimes a little bit more damaging than the pandemic itself, or the epidemic.
I've got a question.
Go ahead.
I dealt with PPE for the Army for 31 years, and as I see it, the biggest problem and it caused all the problems, people getting excited out of Dallas, is that the nurses there were issued the wrong PPE.
Do you want to explain PPE and PPV?
PPE, physical protection equipment. If you watched, and even, I guess it was about a month ago, I checked at the CDC, they were still pushing the N95 mask, which doesn't even have, the Army doesn't even give it a protection factor like they do the military mask. And if you watch the CDC, they're using a pressurized powered respirator or an airline. That has the maximum protection of all. And yet the CDC says they can use the other, the N95. You can buy them at Ace Hardware. They're just dust masks. But let's see where I'm going with this.
Something about how they had the wrong
My mind
mask.
goes around. But anyway, you ended up with 2 nurses that came down with it. Now, they did rush the one nurse over to National Institute of Health in Bethesda, Maryland. And that's a biosafety lab of level 4 that has airlocks and everything. And if you watch the video, you saw the nurse with the powered respirator system. So I am glad to hear that, unlike Hickenlooper, we're not going to be taking people from out of state. We're just dealing with what we have local, is my understanding from the discussion so far. Anything else is just asking for trouble, I think. But PPE is the very most important thing. Do as they do, not what they say.
It is. It's really not airborne, so you really have to have contact.
There's been some debate over that.
I know
Because
there has.
if there's a sneeze, they did say it will stay in
Yes,
droplet
right.
form. And
But
the military and everybody else only uses it in a level 4 lab. So they always err on the other side.
The general guideline is, oh, I'm sorry. Oh, I didn't realize I had it on again.
The general guideline is if you're keep 3 feet away, and while you're getting the person to wherever they need to go, and that's good sense with any infection.
Well, I'm glad to see that. Originally, they were just saying you had to almost ingest it. Later on, they came out and said it was 3 feet.
Right.
But, what they said was okay to begin with. They did change it up. They want more full coverage nowadays. But I wouldn't be happy unless I saw our nurses actually with at least a powered respirator for the COVID.
Okay.
Kevin, do you want to take that?
Yeah, two Kevins.
Oh, that's right, sorry. Kevin B. And then maybe,
Oh,
yes.
okay. So that is a good point, and especially when we talk about risk and economic returns, I mean, we don't want to say that it's purely an economic decision, but we do have limited resources too. So you kind of have to decide between how much am I going to spend on respirators versus sending people overseas to fight this. And it all comes back to limited budgets and hopefully very low probabilities of these things occurring too. But
It's a balancing act. If you have somebody you know has it, at that point, you need to step it up a little bit, because then we ended up with 2 nurses, and all that did was send more excitement out in the community.
it's true, and also, so I think we have similar viewpoints too on transmission. So when we do talk airborne, it's a little bit of a fuzzy definition, right? Because anytime you sneeze, if it's transmitted via fluids, those fluids are now airborne.
That's
How
right.
long they spend in the air and how far they go is sort of this
Not a lot of
division.
research on that.
So within, I think 3 feet is what they've been saying is about as far as it travels, and it doesn't stay in the air for very long. We're talking a few seconds as those droplets fall to the ground. What airborne transmission is when it
They-
lasts
they
and it
themselves
lingers.
basically
It lingers in the
swim
air
in
for a
the
very,
air,
very
yeah.
long time. So if it's a very humid and warm area, when those larger droplets dissolve in the air, the virus can still hang out. And Ebola does not do that. So that's part of where the 3 feet idea comes from, where respirators are not as big of a deal. Because then if you can stop direct...
Oh, I read up on it, but I just see what the CDC does versus what they say.
Well, they also have a lot more resources just lying around
Yeah.
to use too. So if you do have the option between choosing the respirator or just a mask, always err on the side of caution
Oh,
too.
yeah.
Yeah, because it's not a fun disease to have.
Kevin Lamb, did you want to jump into this conversation?
We have a similar approach as far as like how we are going to protect ourselves when we are dealing with a potential patient in the field. We are following the CDC guidelines as far as the appropriate PPE. That includes Tyvek suit, double gloves, boots, shroud, N95 mask, and face protection in the form of a full face shield as opposed to just goggles. We have no skin exposed, and respiratory tract is protected at that point with an N95. Is the current recommendation that we're following.
Yeah.
There's also recommendation based on how sick your patient is and how much fluid is being produced by that patient. I mean, if they're further along in the disease process and they're vomiting, they have diarrhea, they have later stages of the disease, and this is a small percentage based on what I know about it, but there is the potential for petechiae and hemorrhage available, where basically the capillaries rupture, and then there's bleeding from the skin at late stages when this patient is very septic and very near to complete shutdown. So therein lies another liquid transmission source available. So what we look at as far as our patient is how, I guess, dirty are they, or how likely are they to be able to spread that contamination. If it's somebody that has a fever and otherwise is stable, my index of suspicion and how we're going to treat that patient is less than if we have somebody that is just leaking everywhere.
Yeah, it's my understanding as it progresses, they become more and more cautious to everybody around them.
Yes, because
Initially, yeah, but I'm also glad to see that you're looking at the full 21 days rather than just 10.
Right.
We have another question.
Yeah,
Jeff?
it seems like, just to shift a little bit, we had a relatively non-severe dry run of an insect-borne outbreak with West Nile virus. And that was, by most accounts, fairly thoroughly botched by the CDC. Nationally, we had that disease spread from coast to coast in 5 years. Basically, it ran its course. And of course, if you're a human being and you had the neurological symptoms, it was devastating. But the costs were relatively low. Did we learn anything from that locally, such that if Rift Valley fever or another insect-borne disease that's much more severe in its effects were to arrive here, that we would do anything differently? So we had that lesson. Are we doing anything different? Are we prepared any differently now should another insect-borne disease of a much more severe nature come to the United States or to the Rocky Mountain region?
And I guess we should add that there were people in Laramie with,
Oh, yeah.
and I had a student in one of my classes. So maybe what did we learn and what did we do?
I can touch on that just a
Sure,
little
go
bit.
ahead.
Yeah, and I can too. So.
Well,
Go ahead,
we
Kevin.
want to start with Kevin?
Yeah.
Okay, as my role as the hazardous materials coordinator, I work with Keith Wardlaw, who is our pest control specialist for the county. He works for the city of Laramie. His primary job is to kill mosquitoes during the season, and this is not just a thing that happens during the warm weather months. There are actions that happen throughout the entire year. Now, I don't want to speak for Keith, but I do know that when they get ready to ramp up for the adult control season, they start bringing in certain select chemicals that will work well with the fogging applications, either aerially in the donut around the city, and also fogging applications that happen within the city. During the downtime, they're treating standing water during that time as well. So one of the things that they use as trigger points is the mosquito traps that are located around town, and they do counts on those, and they look for a specific type of vector mosquito. And then when they find those specific type, I can't tell you the name because I don't remember it. When they find that specific vector type of mosquito that is known to have the potential to carry something like a West Nile virus, when they get sufficient numbers, they elevate the index of suspicion and will move on to an activity stage, such as now we're going to start doing larval control within the pools. And then we ramp that up a little bit. Now we're going to start fogging. We're going to do aerial application using an airplane. Then if we bump up a little further, now we're doing fogging activities within the city, golf courses, and also going up and down alleys and streets. So as those counts go up or down, the response from the pest control sector of the city, they ramp up or ramp back their efforts. So I guess to answer your question, yes, I think we have learned something as far as looking at that particular illness and where it comes from with that particular mosquito or group of mosquitoes. When they're looking at numbers, we're going to increase our activity or lessen it based on the likelihood of and how many count of mosquitoes we have in that population.
Bill, you had something?
Yeah. And as Kevin was talking about, I actually got a chance to go check traps with Keith's crew this past summer. It was rather interesting how they went about their process, and they look at the pool of mosquitoes that come in. They do find the vector mosquito if they happen to identify one that's a high risk for a type of disease carrying capacity, if you will. Then there's a report he has to send to the state. The state looks at that, the Department of Health sends back information to the CDC, and we start getting notices out. On the public health side, that's where I come in. If it really starts getting to the point where it's getting to a threshold, we're concerned about something, we ramp up the notification process. You were asking about the hysteria. If I can quell that by information, I was at Jubilee Days, I was out at the farmers markets with pamphlets about West Nile virus. I can inform the public, they have to do something with the information. So I had an opportunity to real time actually see what Keith does, and it's again, it was rather fascinating with the reports that go out. And then the Department of Health, their role is going to be looking at those thresholds. Once they get notification of something that's concerned, they're going to send out notices, and they're also looking at the states that border Wyoming, Nebraska, Colorado, Utah, and Montana. They're looking for anything that may actually be brought into the state. Now, during the summer months, we have less of a student population, not as much travel, but you have a thoroughfare through here called Interstate 80 that has a tendency to bring a lot of interesting things that could occur in this county, and we're tracking that as well. So we have a pretty good network on the public health side and the Department of Health side for information. It's a matter of getting ahead of that as best we can to make sure that we're monitoring, following. We had the MERS disease that came out of the Middle East, respiratory disease. That I always mess this with, chikungunya, the Caribbean mosquito-borne disease. Those are things that I watch every week. We get a report. It's sent through several folks in here. Laramie has an environmental manager that also reads those reports. If anything comes up that says, hey, we need to start informing the public, we're going to do it. And we're going to use every means possible to say, you're probably going to have to start wearing more DEET, longer sleeves,
less skin exposure, we'll give you the information as best we can to help you mitigate that. So I think we're trying to get ahead of it, and every time something new comes up, it's a learning process for all of us.
Oh, we've got lots of questions. I guess, Katie, you're first.
My question would be on the first responder and for the hospital people in terms of the emergency department. Has the response and the training that you've done with the Ebola outbreak also reinforced the idea to be looking at some of this exotic things that may be coming through Laramie? Since we do have an international community that comes here through the university, we have Interstate 80 that crosses here, and we know that everything's international nowadays in the matter of a day or a time. Is that prompted your staff to look at those questions even beyond Ebola in terms of where somebody has come from, what they may have been exposed to?
Yes, I think it has, especially with the fact that some of our screening tools are basically, you know, a temperature of, I don't know if it's 100.4 or 101 point something now, and then have you traveled? Those are pretty general questions, and I think that has really opened a lot of awareness for the staff, not only our ER nurses, our ER physicians, but like our admitting folks. You know, they're not clinical folks, but that's the first person sometimes you normally see when you come in the hospital. So we are trying to simplify things in that we're going to act on the side of caution no matter what. And if it is something that, you know, sometimes it's just a gut feeling. If you don't feel right, we've got masks available, you know, to put on the patients, right? When you walk in the door, we've got signs on the door that say specifically, you know, if you've been to these areas of, you know, West Africa and you have a temperature of whatever, please notify, you know, the ER and put a mask on and, you know, that kind of thing. So I think it's brought a lot of awareness to us, and a lot of the, you know, we can't emphasize hand washing, you know, enough. And I think if anything, some of that basic training that we get all the time for hand washing, we go through how to wash your hands every year, just so you know that. There is a specific way that you should do that. And we actually have a guy that comes from our Medline company, and he brings a little black light box so that you do your hands with the hand gel and you put your hands into the black box, and if you miss something, it shows up. Well, I always miss this backside of my thumb every year, and I have to redo it. So, you know, we go through that kind of training on an ongoing basis all the time. We have a scare of any kind, whether it be, you know, an epidemic, a pan flu, whatever that can be contagious. I think it really makes us think about, you know, we do this every day, but I need to be careful because we need to make sure our patients are safe and we can treat them as best as we can, but then also keep ourselves safe and our families safe from getting anything that we might have at work. So it does make us more aware. That's kind of a long answer.
So Robin, then Rita.
Katie asked the question that I wanted to ask, which was about expertise in exotic and rare diseases. So one way to ask it is, more pointedly, is would anyone at the hospital have recognized Ebola 6 months ago? I know we can't have
it's
expertise.
hard to say, but I guess it would maybe depend on what stage that they were in. You know, obviously if you have the petechiae and the bleeding and all of that, you're going to look differently than if you have just a fever and you're vomiting. That's part of the challenge of this, is a lot of it is flu-like symptoms. So, you know.
But the history is as much part of the diagnosis
Yes.
as physical. So
It's not just the fever.
right. So more questioning on where Thomas Duncan had been, I think, would have been called for as soon as you knew he was coming from Liberia, and they have a big Liberian community there. You would have started asking more questions. Have you been around people who are sick? Was there talk of Ebola where you were visiting? Because usually patients have a pretty good idea about what they've been exposed to and what they're worried about. So I suspect he was worried about something when he first came to the hospital, he had very mild symptoms, and I think he was worried, knowing what could come.
I don't know, did we answer your question?
Yeah, that's, yeah.
We
don't know.
I don't know. Yeah, no, that's my best answer.
Yeah, I think
Okay, well,
that's
we
a
have
follow-up.
a question from Rita, and then in the back. Rita, what was your question?
Well, for example, at the university, a lot of times an international student will bring a spouse who does not speak the language at all. And they come from a country, it's not Spanish, because there are a lot of people here that know that. Maybe it's China or one of the African countries. Is there a translation system in place to get a hold of people who can help the hospital and fire department out if you need a translator with these people?
So let me say that louder. What Rita was asking about is people who come and they can't communicate because they don't know English well enough, and it's not an easy language or a popular one like Spanish. Is there some
an unusual country? I mean, it's not
mechanism available to help with the translations? And apparently, yes. Bill?
Yes, I can speak to that. The hospital has a language line, and what that consists of is it's a phone with two headsets, two receivers, and you plug it into one jack, and we have a number that we call, and you speak through one and they translate. You can speak to the patient on one end, the patient speaks through the phone, they translate what that is, and the other person can be on the line. So, and that can cover every language, from what I understand. There are some issues, we have a lot of Spanish-speaking folks in the community. We have several other languages also. I've been told at one point in time we had 39 different cultures here in Laramie, and I do believe that. And how to be prepared to communicate with all those folks. And in the healthcare setting, we have some challenges also in that how they receive their health care, who speaks for that patient, what proper processes after someone passes. Those kinds of things are all different depending on the culture. So, we have some challenges there, but with the language line, at least we can be sure that it's an impartial party. Sometimes if a family member is translating, they may not tell us exactly what that patient wants. We're not sure. If we don't know that language. So we try to stay away from, family members or someone. We have some Spanish-speaking folks maybe in dietary that could come help us, but they're not clinical. They don't know some of those clinical terms. So our standard is to go to that language line, and that's available wherever there's a room with a phone jack.
Okay, so Bill, you had something to add?
Yeah, and then outside of the hospital, if it came to something, let's say a pandemic or a large-scale event, I would be calling the Department of Health at Wyoming, the State Department of Health, ask for assistance in either a specific language. We do have a list of interpreters in the state that are available for that. We also have the university as well, so if it's not a university student, it just happens to be somebody transiting the area or related to somebody, but just is part of the general population, there are means, basically a phone call, and we can track down some folks that might know the language. If not within the state, they would expand it to other places, more than likely Denver, large population center that could probably provide somebody that may know that language, or get somebody on the phone at least to help us initially, because in a large scale event where we're doing a large dispensing, we may have folks, and I have several signs in different languages that may not meet all those, that somebody could read it, but we have a means to track down somebody that could help out if necessary.
I can add that there's a training this Saturday at 10 o'clock, because I'm supposed to be there, for people who want to help in emergencies and who are fluent in the language. So I don't know how many times this training happens a year, but it's happening on Saturday. We had a question in the back.
If someone has Ebola, they sneeze, the droplets go on some kind of a railing. How long are those droplets contagious to someone that might go and hold the railing and then eat and put something in their mouth?
Anybody want to take this?
Do you want to repeat it?
Okay, so to repeat the question, suppose someone does have the Ebola infection or another infectious disease, they touch a railing, and another person, a healthcare worker or another person comes along, touches the same really.
It's a sneeze.
Oh, it's a sneeze, sorry. How long is the droplet that has been left? How long is that droplet dangerous? Contagious.
Well, I don't have this on. I have to get used to that. Not all that long, but while it's wet, it is contagious. So it just depends on the environment and that sort of thing. It was curious to me, there were some of these early cases, like one of the nurses, that they just stripped her whole apartment. They took the carpet out, they took the, they literally just stripped it. The virus would never have lived that long. The carpet cleaning would have been okay. And another one was the plane, with the nurse that went on the plane. They just showed on the media just pictures of every seat being steam cleaned and so forth. It wasn't even, it couldn't have passed on anything after the person left the plane.
So if the droplet dries, can it be reactivated by water or moisture?
No, once it dries, the virus dies. And once it's dead, it's dead. The thing that makes it so contagious is the amount of virus that's in just a small droplet compared to another disease. So another disease might have, let's say, 20,000 or even 1 million. The Ebola has like billions of virus particles in that thing. And so when you just think of the magnitude, it's hard for anyone to live through that if they are actually contaminated with the body fluids.
Sid or Jeff? Sid, you haven't asked a question yet. You want to ask yours, and then Jeff?
I would like to ask each of you who are involved with an agency, what is done within your group to train, to give information to every person. I ask this because a nurse at the hospital who does not work in emergency told me before Thanksgiving her mother was not going to fly to Phoenix to her brother's house because she was afraid of catching Ebola from someone on the plane. And I said, well, you put her mind at ease and gave her information, correct? And she said, well, I wouldn't want to be flying right now because you never know if somebody's going to sneeze on you or touch you or, and I thought, you're a nurse. But my concern is the people here obviously are people who pay attention to the news. There are a lot of people who really don't. They're listening to the cable stations that only operate on hysteria, and they're not really looking at the news and getting information from a newspaper, for example, where they can read, digest the information, and sort it. So what specifically is done in the fire department and at the hospital and at the university and so on to give the proper information and the useful information to every single person who might be needing to deal with this, or with flu, or with tuberculosis, or with whatever the contagion is?
Should we start? Kevin, do you want to start at your end?
You bet, since you directed that one right at me, since you're pointing right at me.
I did.
Okay. All right, that's a really good question. And to answer that, as far as the fire department goes, we consolidated the information, the protocols, how we do our PPE don and doff, how we deal with a patient as far as our infectious disease policies, our treatment plans. That all came to one group. We decided on one way that we are going to be addressing this problem, and then we held a training for each shift delivered by the same people. I was involved in that. I went to each of the shifts from the hazardous materials point of view. I also had one of my firefighters who is the EMS coordinator for our department. He had the EMS side of things. I had the hazmat side of things. Together, we delivered that same message to all of the personnel within our department. So they got the same message from the same people, as opposed to, well, I told Wanda, and then Wanda told Bill, and then Bill told somebody else. And, it goes around the room, and next thing you know, it's like, I didn't ask for pudding.
No. Yeah. Okay.
we are doing, we at the hospital are doing some of the similar stuff. We do have an infection control nurse that is in charge of our Ebola task force, and she does a lot of that sharing of information. We did talk about the fact that we needed to be consistent with our message. We needed to also make sure that everybody had access to the message. We do have 100% of our employees have email now, which was not the case about 5-6 years ago. So we do a weekly newsletter called The Vitals, and it goes out to all of our employees, and we can put in hyperlinks in there to, you know, videos and information. We have done that several times with our little Ebola, kind of a one sheet, fact sheet kind of thing. We have also put in information about our donning and doffing training that we are doing. We have some departments that are mandatory to do that. The first responders that would come to the ER, you know, are ones that do that. And then some of the other units are optional if they want to have that training. We do have a safety fair coming up at the end of February. I know it's a ways out, but we are going to make everyone go through that donning and doffing again, because all of us at some point in time need to put on those gowns and what the difference is between, you know, someone with RSV or pneumonia or, you know, some of the other diseases, as opposed to someone we think that might have TB or someone that we think might have Ebola, because you do different things, you know, for those patients. So we are trying to make sure that our message is consistent. Our Ebola task force meets every couple of weeks just to look at, you know, updates and how we would do everything. So we have flyers posted also, because we know that some people just click through their email sometimes and don't read it always. So we try to get it from several different prongs.
I think you're talking about informing the public.
Right.
And given what happened in Dallas and some of the misinformation that came out and the CDC not always responding appropriately, that's where I think some of the hysteria began. I think the public listens to the media, and so that you're always having that, oh, there's one more case, or, you know.
People are dying all over.
Right. So it keeps coming. Now that there's no cases in the U.S., I think it's starting to die down a little bit, and I hope that it does, because I can't explain why a nurse would be that hysterical, but I've seen it.
And talking about informing the public too, the organization I'm involved with, EcoHealth Alliance, did do a lot of public outreach and interviews. The more senior guys get to go on CNN. I don't get to do that yet. But they did try and spread positive information, but I do think a lot of this is driven by sort of media attention and things like that. If you check Google Trends, it's actually really interesting. Google Trends is a tool that tracks the amount of news articles that come out about something. There was an insane amount of articles right around the end of October, and I don't know what happened in the first week of November that suddenly made everybody lose interest in Ebola, but there was a pretty steep drop-off. So I think a lot of it is driven by people maybe using this outbreak to get some sort of political gain, or maybe hysteria and just the news cycle. There's a certain amount of money to be made if you can make everybody afraid, because if everybody's dying everywhere, people will watch CNN. And if people are only dying in Africa, unfortunately, people tune out pretty quickly.
Yeah, I don't care about that.
Well, for at least Albany County Public Health, I'm one of the people that trains our nurses on N95. I do the fit testing, so one of the things we do discuss is airborne pathogen, bloodborne pathogens as part of the training. That's yearly that we do that. The county nurse manager, who's the boss who oversees all of public health nurse or managing for what we do, she conducts briefings and discussions with all the nurses regarding any changes in protocols that may come down, guidance from the Department of Health or the CDC. She conveys that information to them. As far as other infectious disease outside of Ebola, every day we do TB time test, HIV testing, counseling. Our nurses are exposed to a lot of stuff day in, day out. So they're rather savvy about what is out there, what do they need to know about PPE. Not necessarily on the hysteria side, but they do have family members who do question, hey, are you exposed to this?
Now, one of the things that I've learned in this position is you got to be careful you don't spook the herd. If I put a sign up in the public health office that says, "Are you aware of Ebola?" people are going to start walking out of that office going, "I think we have Ebola in Albany County," because I put a sign up and I was just trying to be informative. So you got to be very careful how you send a message out and inform the public to say, "I'm just trying to give you some precautionary information. We don't have it in this county." Again, you're going to get naysayers that go, "Well, why did he bring it up in the first place?" So it's a double-edged sword sometimes. And I've dealt with it with my family as well. They're concerned about it, and I've had to have that conversation with them. So, okay, here's the reality of what's going on and what you need to know. So they're not afraid to fly, but they still want to drive.
Thank you. I appreciate all this.
That was wonderful. All right, Jeff, I think it's your turn again.
It seems to me that there's this huge elephant in the room, right? And that is the declining rates of vaccination for actually dangerous diseases.
Right.
Right? Polio, right? Pertussis, et cetera, et cetera. That's the scary thing, right? What's being done about the real risks to public health? In terms of education, like Sid's question, I'll bet you that a phenomenally high number of people believe there's an association between autism and vaccines, which is just simply false. I have a sense that if we could defeat that misnomer, we might do more than all the Ebola training that all of you guys could do working 24 hours a day.
I assume everybody heard Jeff's question. And you've heard, of course, that there's an Ebola vaccine coming real soon, right? No, seriously.
It causes autism, so we can't use it.
Yeah. Anybody want to start with this one? All right, go ahead, Kevin.
So one of the things I'm focused on, well, first off, vaccinate your kids and vaccinate your grandkids. But second off, one of the things that I'm focused on in my research is an emerging infectious disease, which is diseases that had been almost wiped out but have a sudden new resurgence, and also new diseases that are coming out of contacts with, odd species and land use changes and things like that. And you're absolutely right. The real threat is stuff that either we don't have vaccines for, or the vaccines are losing effectiveness, or antimicrobial resistant diseases, which are the things you get where antibiotics don't work anymore, which is especially terrifying. Tuberculosis is one of those diseases, which is now starting to become resistant to antibiotics. These are the scary diseases. They're not the ones you hear about beforehand, because some of them we don't know what they are. So in general, a lot of the preparation that you can do for it involves either stricter environmental rules and things like that, stricter rules for everything from agriculture to trade, making sure things are healthy. Like SARS came from a poultry worker in China, and then was carried to Canada on an airline or on a jetliner. So clearly stricter health controls and things in China might have been helpful, and also building up infrastructure in developing countries, because one of the things that we're starting to find out is that you can't keep up with this threat if you're always sort of chasing the horse after it got out of the barn. So you have to build health infrastructure, send doctors, and do things to improve health in developing countries, because that's where a lot of these things come from. They sort of percolate over there, they build, and just like we're seeing with Ebola, you have imported cases, you have cases coming from overseas. I would bet the next pandemic is not going to start in the United States, but there is a chance it would come here after it starts somewhere else, and that's relatively terrifying. And you can't wait for something to come to your... I'd hate to say that quote from the 2000s, you don't want the smoking gun to be a mushroom cloud type situation. And we have to be proactive and deal with these things overseas before they can come here. And part of that is funding organizations like GWARN, the Global Outbreak and Response Network, which is a part of the World Health Organization, funding organizations like Doctors Without Borders, and then also sending things like the CDC to work overseas with other countries' health departments, and also just physically building hospitals and sending doctors, because a little bit of general public health goes a long way when you're talking about fighting the threat of pandemics, or a little bit of hygiene, improved hygiene access and things like that. I think it's Bill Gates who's working on a better toilet or something. And that would do a ridiculous amount to reducing the threat of these sort of diseases, because you kind of nip it in the bud.
Would you say the name of that again? Global Health what?
It's the Global Outbreak and something Response Network, but I can't remember off the top of my head, but it is a part of the World Health Organization. And they get most of their budget from gifts from donor countries. And by donor countries, I'm mostly talking the UK and the United States. But those donations were actually reduced right around the budget crisis in 2010. It was one of the things that we decided could go in the name of trying to balance the budget. We still do give a lot of money, and we still do really great work with them, but they could probably use a little bit more money and a little bit more funding and a little bit more help, because I think they have like 50 people in their office, and the world is very big.
I just wanted to say, it's not just diseases, but there was an article in the New York Times today about what's happening in India with where they have typically given babies as they're born several doses of antibiotics. As you might guess, in India, it's not quite as sanitary as it is here, and so many babies pick up an infection. So just preventatively, they have given these babies. And now, some of the older babies, they're getting sick, and nothing works. And the spread of those resistant bacteria is very scary.
Molly, I think you had a question?
Yeah, this is kind of an economics question. I understand that, you know, how long has Ebola been around? 30 years? About like that, right?
Yes, I think the first documented case was in 1976, and there have been close to 30 outbreaks since then.
Yeah,
so it's relatively
and
regular.
none of the pharmaceutical companies have been working on a vaccine simply because it's not profitable.
Yeah.
So how do you get around that?
Government. And actually, so the United States, I think they are either considering or they recently listed Ebola as sort of an ignored disease, so that it's eligible for more subsidies and things to develop a vaccine. Although now, of course, there's also a rush to develop a vaccine simply for humanitarian reasons. But it is one of those, it's very hard to convince people to make a vaccine for a disease that typically is an outbreak in a small village and then burns itself out very quickly. So that's also the big difference this time, is normally Ebola pops up in a small village, never goes anywhere and burns itself out. And everybody was always sort of content with that. But this time it happened to get into a city and the outbreak got much, much larger, and now we're dealing with the fact that we never well, I'm sure a lot of people look seriously at this, so I don't want to discredit what anybody did. They just didn't have the resources to come up with a vaccine before.
There is some hypothesizing that the Black Plague wasn't really bubonic plague, but it could have been Ebola. And the historians are talking about how fast it spread. And bubonic plague, you know, it's hard to get those fleas to go very fast. It would spread much slower. And the number of people. So I just thought that was interesting, that it possibly could have been.
What a great panel, don't you think? Yeah. All right, anybody else want to add something more to that? Ollie, did we answer your question? Anybody else?
I just didn't think economists would ever say the government should do anything.
Well, this is a guy who's an happy guy, right? Remember that?
That's the benefit of picking an environmental economist. We're a little bit more open to government intervention than some of our friends.
All right, so.
There's a real big chink in the armor of personal protective equipment for protecting yourself against infectious diseases, and that's taking off the contaminated suit and not contaminating yourself while you do that. And I really want to compliment the hand washing strategy where they use the light to show you, okay, you didn't get that. But in pharmaceutical industry, they work with some things that are enormously potent. They do the same kind of training of their people to show them how easy it is to get this stuff on you without even thinking about how you might get it on you. And so they put a tracer of some kind that fluoresces, and people go about doing their things, and they put some of this stuff there, and then they shine the light on people, and everybody thought they were doing things really well, and they got this stuff on them. And doing something like that with the donning of personal protective equipment would really go a long way to showing people what they're doing wrong, if they're doing something wrong, taking that person technically wrong. I don't know if that practice is used or not.
We actually checked into trying to get some of that substance and have not been able to do that yet. But a couple of the things that they have changed with donning and doffing of PPE are, as we step up, our training for Ebola is you must do it with a buddy. You never do it alone, and you have that buddy watch you and help you get your gown off so you're not contaminating yourself. That is one thing that is new. And then also the guidelines, latest guidelines that our task force looked at also recommended after every step, say no matter what order you're in, take off your hat, you hand gel. You take off your mask, you hand gel. You take off your booties, you hand gel after every step of that process. And the only thing I can think of is I think the alcohol gel companies are at work in that one. But more training, and things will change and we're always learning. But those are two things that we've added for sure to our process, and let alone the different steps. We have, if you have your whole body covered, you have either booties and a gown, or you have a Tyvek suit with a zipper, plus you have goggles, plus you have, and one of the things that is different for us too is all this stuff has to be impermeable. It has to be waterproof. So different kinds of mask, goggles, and then a plastic face shield with a hoodie over the top, even though you still have a Tyvek suit on, taping some of those seams and taping. We have 3 pairs of gloves also, and taping those. And one of the reasons for 3 pairs of gloves is that you can take off your outer 2 and you still have a clean pair to take off some of your other things. So there are some updates with some of those old processes.
Dennis, it's yours.
I'm still a little unclear about something. Supposing that one week we do in fact have a person with Ebola in Laramie, and then the next week 2 more people come down with it. Is there somebody or some office that now suddenly takes charge of what needs to be done throughout the community? Is that you, Deb?
I'm nodding my head in agreement. As soon as I find that office, I'll let you know. No, actually, that would be public health. We would be doing the monitoring. That's when the county health officer starts becoming essentially what we would call the incident commander, and working with the hospital, the CDC, the Department of Health from state of Wyoming. We all get involved and we start looking at the contact piece, the monitoring, isolation, quarantine. We look at all of those factors and bring those into a discussion with the main stakeholders in the county, which would be the county commissioners, the city council, anybody who would need to know to help either pass information on or help us in regards to reducing any further spreading of the disease. So it's going to be a lot of research, but county health or public health would be the lead agency that would be doing the conducting of interviews. We conducted a tabletop exercise on exactly that. It was introduced into the county. I had all the jurisdiction partners. Some of those 30 people or those 30 agencies we were talking about, I probably had about 23 or 24 represented that day. And it was rather interesting because it was a good snapshot to see how everybody would react based on an escalating issue. It starts with one person, goes to the next. Now you got family members, and now you've got first responders that may have come down with it. Now you got to go into isolation. So we took that and evaluated what we would be doing, and the county health officer was in that meeting that day, and it was an opportunity to discuss exactly how this county would go about, again, trying to mitigate the problem if it were reported. And we'd also get a lot of help, whether we want it or not. It's coming from the state and the federal government, pure and simple. As soon as we get an indicated or any type of case reported in this county, we're going to have a tremendous amount of resources coming our way to help. Epidemiology would be one of them from the state. So yeah, it would be Albany County Public Health.
But statistically, that's not likely to happen. You can see with the cases that the contacts haven't come down with it. I think they were following at one point just hundreds of contacts, some intimate family contacts, and even Thomas Duncan's family, they didn't come down with it. So I think it's harder to catch than we think it is. But in West Africa, where you can't get to the toilet, there's not one close by, the whole environment and the culture of washing dead bodies, you're washing your family's body. In Mali, there's some cases now because a religious leader came through, and in the public fountain, they washed his body. The whole community did, and so Mali didn't have any cases. It had one baby, and it was considered free of Ebola, and then this happened. So now they have an evolving situation.
Well, I was just trying to imagine a worst case scenario. And I'm getting the impression that maybe there's going to be lots of people sitting around the table trying to decide what is the best thing for Laramie to do right now. Is there, you're the incident commander? I mean, is it your decision or?
No. What would happen is we have plans for infectious diseases on the shelf.
Different kinds.
Yeah, for different types of outbreaks. If it's man-made, like an anthrax attack, that's a bioterrorism type thing. But if it's natural, tuberculosis, brucellosis, something like that, or even Ebola, we have plans in preparation. That's why we do tabletop exercises. That's why we drill that, so we can talk about that and talk about, okay, I know what Wanda and the gang are going to do at Ivinson Memorial Hospital. I know what Kevin and his crews are going to do when they do a pickup on a patient. If somebody does self-transport, I now know that as a public health official or a member of that county agency. Now I can kind of figure out what they're going to, I'm not going to do their job, but I know what it is. And now I know how we can react. So it's by that passing of information and communication amongst all of us and working together, we're a step ahead of the game. And as they say, the last place you want to be exchanging business card is at the accident. So if we do it now, I know who I need to call and why I need to call them. And we're probably going to be, as the doctor said, it's going to be isolated. It's going to be, one particular area. We'll go and focus on that, but at least we're not running roughshod all over the city trying to figure out where is this problem, because we decided not to talk to one another. So we have good plans in place.
And that includes keeping the public calm.
Absolutely.
Calm. Even though they know somebody from the CDC had just arrived at the airport.
Yeah. The information process is key to that, the communications. We have it, actually I can maintain the chapter, at least on the public health side, and I work with the county emergency manager on what we call public information officers. Somebody will be a spokesperson, either from the hospital or from public health, that will probably twice a day, we figured what we call a battle rhythm. 8 o'clock in the morning, 6 o'clock in the evening, we'll be on the news and saying, ladies and gentlemen, here's the latest update on what's going on. We're going to try to lead turn any misinformation that's going out there with real cognizant, positive information about the situation and try to answer as many questions as possible. There will be lots of conversations in front of the hospital or numerous locations throughout the city to keep the public informed of what they can do to mitigate the problem or to possibly prevent hysteria. You can only do so much, but we're going to do our best, that's for sure.
I think I'm sorry about it.
No, that's okay. And I just wanted to tag along too. There's one advantage that we have when it comes to controlling things here, and it's our ability to do things like contact tracing is just amazing, because especially compared to a developing country where you don't even have addresses, much less, or even roads necessarily. It's just, hey, there's somebody infected down by the river somewhere. We're able to do contact tracing, to the point where the doctor in New York, they knew he went bowling, who was bowling at that time, traced everything. So if it shows up, we have a really amazing system in this country to sort of control that stuff. And I guess my fellow panelists sort of thank for that more than I am.
Lynn,
Yes.
public announcements, when they come across on the TV, you cannot understand it. It comes across, so you're wondering what the hell is on the TV? What are we supposed to be learning about?
Okay, so you're going to address this, right?
Correct that problem.
Okay, there's several ways we could do it. We could use social media. That's a beautiful thing. Facebook is a rather surprisingly good way of getting information out. For folks who don't have internet, we also have the radio. We're going to be using the local radio stations. If we don't just have, or if we have television as well, We have a way to get information out through messaging, texting, phone calls. We have a system called Code Red. We have a lot of ways to get information out. We can tell people through the Laramie Boomerang, through the Boomerang, where we're going to have a press conference and what location. So the idea is if we get more and more folks and they're really interested and they're concerned, we can expand the venue to some pretty large locations. Albany County Fairgrounds, UW, if we had to go there, there's an opportunity to talk to the university and see if we could use one of their venues. And if there's 20,000 people who want to come out there, we will find a way to get that stadium open and we will tell people what's going on. Hopefully the PA system at UW is not as bad as the TV though. But
it's an Alzheimer's patient and baby use or an Amber alert or whatever, it just is almost impossible to understand what it's about.
It's electronic voice.
yeah, we have shorthand radios, ham radio operators. We have a pretty large network available that we can get information out, and it will go across a tremendous amount of different ways. It could be even door to door if it has to come down to that. We would.
Glad you mentioned the ham radio group because I know they've been very involved.
Yeah, great bunch of folks. They can get a lot of info out there for us. Yes.
Rita?
Does, we're fairly high altitude here, over 7,200 feet. Does altitude, higher or sea level or a hot climate or a dry climate have any effect on a virus like Ebola?
Well, I would just say, in a drier climate, you're going to have droplets disappearing fairly quickly. But I don't think there's been any research to show, in terms of altitude on Ebola. There's been very little research on it anyway. It's sort of a desperate thing when a community starts to get this spreading disease and whole families are dying. The researchers really aren't there.
Katie?
One last question, because I know we're getting ready, close to wrapping up here. You all have access to professional journals and information that we don't have access out in the public, and the news media coverage has died down. Do they have a best theory now on how those 2 nurses did become infected in Dallas when so many hundreds and hundreds of other contacts in other hospital settings, no one else has been infected?
Well, I'll give my opinion, and the discussion groups have really talked about it being a breach. That's why the donning and doffing of the protective gear, they didn't even really have their necks covered, so it was that kind of thing. But you're right, there are a lot of, I got in on some of the earliest discussions about Ebola with Washington and the national nursing organizations and the medical associations. So just by kind of being on the alert and getting in on that early, I was able to find out a lot of information in terms of planning too, because it didn't come readily from CDC quite as clean as we would have liked it in the beginning.
Jeff?
Just one last question that kind of went back to mine about communicable diseases and vaccination. Can anyone tell me what percentage of Laramie's population is not vaccinated against whooping cough? Shouldn't we know that?
I wonder if we know whether we're vaccinated. Anybody have an idea?
Yeah, I can get you the information. I didn't bring it with me, but we do keep track of that data. I know that in public health, we do offer different types of vaccinations for all age groups, but I don't have that with me. But it is through public health you would get that information because we're required to report that based on our dosage and what we administer pretty much every day. We have monthly, quarterly reports. So the Department of Health keeps track on that for the entire state of Wyoming as well. But yes, we do know that information.
And what are you doing to encourage vaccination and to discourage misinformation about the dangers of vaccination? I don't see a whole lot of messaging out there.
I would just say right now that they're going after the target audience. Who's most susceptible to it? So our nurses engage in home visits with families that have maybe young children, or some of our nurses visit the nursing homes in town. You have the elderly who are more susceptible to certain things. So I just remembered I think it's the pneumonia Vaccines are for over 60, 65. They have certain measures you need to do, get a booster, so on and so forth. So we engage those target audiences directly, rather than just send out a blanket announcement, and it may not apply if you're from 18 to 50. We go specifically to those organizations, and we have nurses that do almost on a daily basis. Some of our maternal health nurses go out to brand new mothers and parents, and they talk to them. We also have the WIC in our office, and they get referrals. If somebody is concerned about vaccinations for their children, they're eligible for certain things under Medicare and medical needs that we can give vaccinations either there in our clinic, or we get referred to the hospital to get them proper vaccinations. So it's a targeted effort. It's not a blanket effort, because not everybody needs a certain type of vaccine. So we try to keep it focused on that. We work with the schools when it comes to school-age children. The university does a real nice job when it comes to student health and informing, hey, you come to the university, your vaccinations aren't up to speed, maybe it's something you need to consider. So there's again, target opportunities there, if you will.
Can I ask something? I mean, to that, to be in public school, you are required by law to be immunized, except if you have a medical waiver or you have a religious reason.
Or you simply make a decision not to.
No.
No. You can.
You cannot.
But the criteria for the religious waiver is I don't believe. Right? Like you can simply assert.
If you claim a religious faith, I do not know what, and maybe Lawrence, you're here, maybe you can answer that, of what.
But there's a bigger population of those people who don't want to get vaccines.
But you have 30 days from date of enrollment in the school district to
Okay.
be immunized for all the required immunizations that they list in there, unless you have a medical waiver or a religious waiver.
One comment I would make just about our hospital folks. We made it mandatory this year for all of our employees to get the flu vaccine. It used to be optional. And I can't tell you what the percentage is, but I'm interested and I'll find that out, unless they have a medical waiver. It is mandatory. And the reason for that is we want to protect our people, but we also want to protect the patients from getting something that we may transmit. And the data is out there. It's proven that that's a good way to prevent the flu. So it was mandatory this year.
Back to your committee that you referenced earlier. I think it would really be good for this community to work with the Boomerang and maybe the news stations, radio, probably, to have some sort of regular information about what you're doing. Because we don't hear from you. We didn't know about the community, and we don't know what's happening, and we assumed the hospital was doing Ebola training. We didn't know that. And I think the public would benefit from knowing what the fire department does, what each of your units does, what's happening on campus. And I think so people would look for it and know, that there would be information forthcoming. I think the public doesn't have enough information. It doesn't need to be lengthy, but just, something that informs people and reassures them. When the Ebola thing was hot, and I suppose it was the end of November, and probably it was getting kind of partisan, which was really strange, but there were a couple people who wrote letters to the Laramie paper, basically I'm going to get Ebola from a toilet seat kind of thing. And no one from the health community wrote back to disagree with that. I was really disappointed in your people, that no one stepped up and said, here's some information, and I think that should have been countered immediately. I kind of kept looking at the paper day after day, and there was nothing. And I thought public health or IMH should have been right at the forefront, and nobody did anything. And yes, it did die once the election was over. But I just don't think those things should be floated out there and then ignored, when there is some factual information that could be helpful to everyone.
I'm in agreement with you. I will just tell you that guidance does come from above as to what we can and provide out to the public. And it doesn't mean we're stifling.
Who is your above?
That would be the Wyoming Department of Health. They have what we call a PIO, information officer, who is assigned to the Department of Health for exactly that information. The way they look at it is they send out statewide notices. They're not going to go down to the local level. We can have information from the state come into the Laramie Boomerang as an article that's been signed off by either the state epidemiologist or Dr. Braun, the director of the Department of Health. And that's where they want the information to come from. We're not going to get into a street fight with people regarding their personal beliefs and stuff, but we do have a responsibility to inform them.
Right.
So we won't address a specific concern, but we will give you the generalized information so people can make that informed decision on their own. So if that was the case and you weren't seeing enough in there, that's something I can definitely take back to the county nurse manager and say, hey, probably something we need to look at a little bit more often. And when it comes to these things, is maybe a little more information to the public. Perhaps it's a weekly thing, maybe it's a monthly thing, say, hey, did you know about this? But that is our role, is the information process. But we're not going to take it to the one-on-one. That's not what we want to do.
No, and I didn't expect that.
Okay.
I just thought there wasn't any information at all
Yeah.
on the local level from anyone.
And I've taken that for action.
And I thought,
Mhm.
I almost contacted the county commissioners and said, don't we give money to the county health office? And if so, they ought to be earning it so far as PR. But I, easy to contact.
One thing I would like to add to that too is a lot of it is controlled by the paper. What they put in, what you give, what they decide to put in, because the hospital has had many different things that we've tried to address and do, and a lot of it doesn't get in. So some of it is controlled that way. But
Sure.
I think it's a great idea though.
If they're just something short, even in a little box that people knew to look for.
All right, well, I think we're all chastised now, and we'll think about it. But maybe we should allow our panelists to make their own last statements. We were supposed to wrap up at 9, and I really didn't think it would go till 9, but it's been fascinating. So, panel members, would you like to add something? Start at the end. There we go. Kevin.
Well, I appreciate the opportunity to be here and give the information that I could regarding the job that I hold and the responsibilities that I have for this community. And if you have any questions regarding what we do individually at the fire department and what we do as far as our interaction with the ambulance, fire suppression coverage, how we deal with hazardous materials, you can get a hold of us. We're in the phone book, the non-emergency number. You can give us a call, and we can get your question answered to the best of our ability. Thanks for having me here. I appreciate it.
Thank you for me also. It's good to get out there and at least hear some comments about it. I believe we are doing great things at the hospital and with our county, but sometimes it's not shared and people are not aware of that. So if you guys have any questions for me, my last name is Hewlett. It's spelled kind of funny. It's not like Hewlett Packard. I wish, but it's Hulit, and you can call me at the hospital. I'm the only Wanda in the whole hospital, so just call and ask for me.
Working at the university, and I'm not ruled by anything, we have academic freedom, I would think more of our nursing faculty would be answering something like that, but people get distracted, and so I will encourage them to do that.
I guess I'd also just like to say thanks for the opportunity to come out and spend the evening with you guys. It's been a lot of fun. As far as my research, Ebola is kind of a wake-up call to this kind of problem, so it's good to see people are interested in the local response, but we also need to start taking into account what we can do sort of internationally to fight these threats, because especially given things like globalization and climate change, this is not going to be the last time something like this is a threat, but it is a chance to start doing something proactively, make sure that next time it's not as damaging. And if anybody does like to contact me, I think my email is listed in the program, and I'd be happy to answer questions and stuff. And also, being a graduate student, I have academic freedom, and then on top of it, I also don't have to worry about staying in the department very long because I'm on the job market, so I'm free to say whatever I think. So, be forewarned, you will get an honest answer for any question. Yeah, thank you guys.
Well, being as I have zero academic freedom and I do work for the county, I'm here to tell you I'm here for you. That is my job, is to help with preparedness, not just local responders and jurisdiction partners, but it is with the community. So always reachable. The county public health office is on 2nd Street across from Napa. If you ever have any questions or you want to contact me regarding preparedness, infectious disease plans, anything of that nature, that's what I'm there for. That's what they hired me to do, and I'd be happy to answer any questions I have. If I don't have the answer, I will come up with one or I will find you one. So that's what I'm here to do. Again, been a pleasure. Thank you very much for this opportunity.
Really good panel.
Just fabulous, right? And on behalf of the League of Women Voters, I give you our co-president.
I forgot to tell you, leagues all across the country do a publication called A Look at whatever their local government is. We no longer do one in Laramie because we thought it was no longer useful, but we still have a few copies of Look at Wyoming Government, which was done on the state level. We used to sell these, now they're to give away. If this is something you can use or you know someone who can use it, please feel free to take one there on that table over there, and there's also a little information about the league also, league membership. And if you have any questions for us or requests, we're happy to take those. So, okay. Anyway, A Look at Wyoming Government. This just kind of breaks down how Wyoming government operates. It's way out of date. That's why we're giving it away. So you'll look in here and see a previous governor listed and so on. However, it's very useful, and this book has a chapter on tribal government, which other Wyoming government books do not have. And so if you're interested in tribal government, there is a chapter here. We did get some up to the reservation so they too could have it. So thank you all for coming. Good night.